Ryan Stanton here with ACEP Frontline, joined by a returning guest, Dr. Peter W. And we are talking a little COPD, or as I like to call it, COPD, and opportunities. A very common presentation, especially for my area of the country here in Central Kentucky, but across the country, it's a common diagnosis that we deal with, and one that is prone for bounce backs and readmissions if necessary. And so another one we can kind of focus on, I think it and CHF are two of the most common bounce back diagnoses in the emergency department, of some of the choices that can be made that can lead to that. So first and foremost, give us kind of a refresher background on you. We'll roll from there.
Sure. So appreciate it, Ryan. My name is, as you said, Peter W. My training's both in emergency medicine and pulmonary critical care medicine. And I practice both, and have for the last 35 years in both the emergency department and the intensive care unit at what was Charity Hospital and is now University Medical Center at New Orleans.
Well, I was just down there, so since we last talked, I've been down there doing a little racing in the New Orleans area down at NOLA Motorsports Park. Great place, and I'm jealous. I don't know how you don't weigh 800 pounds because the food is so good down there. So kind of dive into where we are right now with COPD.
So COPD, as you mentioned, Ryan, is the bane of our existence because we have lots of folks who present with undifferentiated shortness of breath, who have longstanding history of smoking and tobacco use. And so our struggle is always, are we dealing with just COPD, or is it COPD and heart failure, or do we have something with pneumonia? Do we have to consider PE? It makes it a little bit tough for us. So classically, COPD is increasing in dyspnea, right? So our patients are presenting with shortness of breath, plus or minus increase in production of sputum, and then plus or minus whether that sputum is looking purulent. So did it change from clear to yellow to green to brown to rusty colored? And if you get 2 out of 3 of those, you're probably dealing with COPD. But we still have to exclude the other diseases. You still have to exclude that this is not congestive heart failure, that this is not a pneumonia, that this isn't some overwhelming, viral infection. It could be a whole host of things. So it's a real broad differential diagnosis. And the real requirement for the diagnosis of COPD, and this is where it's tough in the emergency department, is you need spirometry. And this isn't a shout out or a call out for the emergency department to get spirometry, because the worst time that you can possibly schedule and perform spirometry is in the middle of an exacerbation. So the diagnostic benefit of spirometry is when you're at your baseline. And that's a big learning point for our audience, to kind of look, if you're entertaining COPD, getting it in the patient's head and in their primary care follow-up, that they need spirometry. And that spirometry is what really is the gold standard for labeling someone as COPD and helps us differentiate between chronic bronchitis, asthma, as well as emphysema, or the mosh pit, combination of all of those.
Yeah, I was about to say, it typically does seem to become a mosh pit. The 2 patients I admitted with the CHF exacerbations yesterday also had the COPD with it as well. And so those coexisting conditions in the population now mean that we have multiple factors that are really playing on the lungs and leading that patient being admitted to the hospital. And sometimes it's hard to see which one is the key player, the conductor of the orchestra for that day. And I think that. Are we seeing more of that kind of comorbidities of pulmonary pathologies, or is it something that's just always been there and just they all kind of interplay and kind of a balancing act?
I think we've always seen it. I would tell you this, though, that the advent of COVID made this so much tougher for all of us, right? Because someone who presents with COVID or with influenza, with a baseline history of longstanding smoking and congestive heart failure, I mean, that's that's a tough diagnosis to make, right? And that's our undifferentiated respiratory distress patient, and figuring all that out. But the benefit of a BNP helps us not necessarily exclude heart failure, but move it down on the list.
With that being said, if this is one that, you've got your NEBs, you have your steroids, you have all those things that we've done for decades now. What has changed, or there's been any evolution in you mentioned PFTs for the diagnosis, but in terms of our addressing the diagnosis or an exacerbation when it arrives in the emergency department?
Yeah, I think one of the things that I would remind folks is that unlike asthma, a standard asthma patient doesn't require a chest x-ray, right? For that diagnosis. History of asthma, you're treating them, they're getting better. We don't need a chest x-ray. In the setting of COPD, right? That chest x-ray about 20% of the time changes management, right? We'll show something new, something different, whether it's an infiltrate, whether it's a pneumothorax, whether it's hyperexpansion or atelectasis, or an effusion, it's going to offer some utility. So that should be a standard if we're dealing with COPD. And I think that that's an important understanding. You were right to say our NABs and our duo NABs are the standard. We're going to reach for that. And the steroids at 40 mgs, PO, prednisone, to start off with, is something we're going to do. If I'm so sick that I can't tolerate anything PO, then I'll give Solumedrol at a dose of 125 because we do. Not because there's powerful evidence behind that, but that's just the recommendation. If you're that severe, we're going to go with 125. The other piece that's a little bit nuanced now is going to be antibiotics. And antibiotics are not a standard for your COPD exacerbation. And there's some strong considerations. If you're admitted to the hospital, you need to give strong consideration for that. If you have new chest x-ray findings, obviously a pneumonia, something like that, we're going to start with that. And the antibiotics are either going to be something along the lines of amoxicillin, clavulanic acid, augmentin, doxycycline, or azithromycin. One of those three players, if you're sick enough to be admitted, or you're having new infiltrates, or you think that this is most likely to be severe in your COPD. Understanding this, that when we have color change in sputum, that's a function of myeloperoxidases, fancy words for stuff that white blood cells make. And so that color change doesn't necessarily mean infection, although I did say white blood cell just now. But remember that white blood cell can be activated for inflammatory conditions, right? And so that can cause color change in my sputum as well. So the little bit of nuance change is not everybody gets antibiotics, particularly if you're discharging somebody home. That's not classically something that we do.
And kind of bouncing back a little bit to our last time together. So Dr. Peter W. Was joined with Dr. Jim Neuenschwander back about 5 months ago for a moderate airway management tool that we have as well. Kind of give a little recap. Well, I want everybody to go back and listen to that podcast, so do that too, but kind of give a little recap on where we are in terms of the management, because high flow humidified nasal cannula has really took off during COVID. We've got, kind of the hesitancy for intubation of these patients, kind of addressing and that stepwise management of the airway in these COPD patients.
Right. And so when we're talking about mild disease, respiratory rates less than 24, heart rates less than 100, we're talking nasal cannula use, and anywhere between no oxygen and 4 liters per minute. You could consider veni mask, right? 24 to 40% if the patient isn't meeting their needs with the nasal cannula. Here's the important point. If the patient's on HOMO2, maintain them on their HOMO2 and do your assessment while they're on their HOMO2. we wouldn't be surprised if someone's requiring, 3-4 liters of nasal cannula at home and they're on room air, that they would be hypoxic in your space. So just be mindful of that. When we talk about moderate acute respiratory distress with COPD, respiratory rates, greater than 24, heart rates greater than 100, some moderate accessory muscle use, no real change in mental status. In other words, they can participate in their care. If by chance you got blood gas on this patient, pH greater than 7.25. And so the choices there, again, can be nasal cannula, can be veni mask, but now we're going to talk about high flow nasal cannula, starting flows 40 to 60 liters per minute, and then titrating FiO2 for saturation goals. This is big, saturation goals, 88 to 95%. You really don't want SAT goals greater than 95%, and you're very happy to tolerate saturations at 88%. So this golden moment or golden target of 90% saturation is not associated with any outcome changes. So we need to know that. And COVID taught us a lot of that, and our ability to tolerate saturations less than 90 and the patient doing just fine with their outcomes. When we talk about other positive pressure ventilation, non-invasive measures, we're talking about BiPAP. We would start initiating IPAP at 8 to 14, and then the EPAP at 4 to 6. So we're just understanding that's where we would start our folks. And then again, if they're woefully ill, we're talking respiratory rates in excess of 30, heart rates greater than 100. And this is after our duonebs, after our supplemental oxygen. They're using moderate to high accessory muscle use. They have a change in mental status. They may be now agitated. Their blood gas is less than 7.25. Then we're going to talk about, we're going straight to the non-invasive work, just head straight to there in preparation for mechanical ventilation. Because if they don't turn around quickly with our non-invasive, whether it be humidified high flow nasal cannula or whether it be our BiPAP, if we give them a trial 10, 15 minutes and the respiratory rate's still high, they're still confused, we're not reaching our oxygenation goals, while we're administering that, we're preparing for RSI, right? We're preparing to intubate this patient. If we don't have to do it, gift from God, right? Thank you very much. That's lovely. We'll get the patient over to the corner and just monitor them closely. But if all that aggressive airway management with the non-invasive work hasn't budged us, and we're still having high respiratory rates, lots of accessory muscle use, and a confused patient, we're going to intubate that patient, right? We're going to make sure that we do that. And that's critically important. Their initial, 1 hour treatment, if their PCO2 is going up, whether we're using end-tidal CO2 or you're using VBGs or ABGs, that's all appropriate. Or if they have increasing hypoxia, concern for airway protection, decline in their mental status. If they're tiring out, they came in there with a respiratory rate that was 40, and now it's gone to 30, and now it's gone to 20, but they're not looking good. It's not like I'm looking great, I'm feeling much better, 2 thumbs up, and my respiratory rate's 20. It's like I'm a bit confused now, my respiratory rate's going down. That should be a red flag for those listeners, and we need to think about moving forward with intubation.
Let's chat about this tool. I mean, we saw you last time. We had the moderate airway management tool. So let's talk about where we are here with the COPD and tools that are being developed for our emergency physicians to assist them in the management of these patients.
Yeah, I think the strength of this tool is probably in the disposition piece. That's probably the value added for the listeners, right? And so if we're talking about discharging somebody from the ED to going home, we're talking about mild to moderate symptoms who responded well to the initial therapy, and they don't require additional oxygen. Put a pin in that for just a second. If the patient's on HOMO2, they're now in your care, they're doing better, but now they required more oxygen than they have at home to reach their saturation goals of 88 to 94, 95%. That patient needs to come in. They can't go home, right? So if they have escalating needs for their oxygen, that's a marker for severity of disease. That warrants coming in. So I think that that's really important. The other thing that we stress in this tool is assessing patients with a walk test. So you've treated them, they now look great. They're, they're sitting in the bed, everybody's pounced on them. You're given everything you need to do, right? Your steroids, your duo nabs, supplemental oxygen if they needed that. Now let's get them up and let's ambulate them, right? We're not talking about doing a mini marathon. We're talking about a lap around the ED and then reassessing their vitals and reassessing their oxygenation and reassessing their symptoms. So if that simple measure of activities of daily living, what they're going to be going home to, right? They're going to get up, they're going to go to the bathroom, they're going to get up, they're going to go to the refrigerator, the kitchen, and they're going to go back to the recliner or back to their bed. If that little mini stress test tips them over the edge, they need to come in. They need to come into the hospital. And I think verbalizing that in a point of care tool is critically important because we've all seen bounce backs, and in COPD, bounce backs have been as high as 33%. 33%. So 1 out of every 3 patients that you're discharging out of the door are coming back to you. We all hate that as providers. We don't want to see that. And so this helps prevent that, right? And so if you don't pass the walk test, you need to come in. That's a good test, not just for COPD. It's great for asthma. It's great for congestive heart failure as well. And those people with, moderate respiratory distress that you're bringing into the house or considering discharging home. When we talk about floor admission, we're talking about those patients who maintain moderate symptoms who didn't fully respond to the initial ED treatment, right? And persistent symptoms despite that, and patients who also have new oxygen requirements or increasing oxygen requirements can go to the floor. Those people who have competing comorbid conditions. So I have CHF and COPD, right? Those two things. I'd be hard pressed sending those people out without at least 23-hour OBS admission. I think that that's important. New conditions such as pneumonia, because we know that pneumonia is going to progress over the next 24 hours, even with the right antibiotics. Maybe those people with dysrhythmias, and those people that you consider the diagnosis of sepsis as well. So I would do that. And then also, we talk about this a lot, is those folks who suffer with social determinants of health, whether it be medication insecurity, housing insecurity, food insecurity, those kind of things are important to think about for those patients. And then who gets admitted to the ICU? And again, those are patients who have moderate to severe symptoms that are requiring new non-invasive positive pressure ventilation. So if they've never been on humidified high flow nasal cannula before, and this is new to them, this is an indication, that ICU is an indication. If you are titrating BiPAP, that's a trigger for you. If you're titrating BiPAP, don't try and put that patient on the floor. Don't make that mistake, because who knows who's going to check on them, whether it's going to be nursing, whether it's going to be respiratory. And if you're titrating that, they're not in a stable, great place to be. If they're on their home BiPAP and they're stable and it's moderate, you can consider that to the floor. But if this isn't their home BiPAP, or we're having to titrate up their home BiPAP, and this is moderate to severe, they need to be in the ICU, and that's going to be the push. The other thing is also consideration for palliative care. And so go into the patient's records, see if they've had goals of care conversation with their either primary care provider or palliative medicine before, to understand, is this somebody who's been intubated before? Many of our COPD patients, the brittle ones, have been, and many of them say, I don't want that again. And so that's huge information for us as providers. So we have to ask, have you ever been intubated before? Is that something that you would consider again if you needed it? And so to have that out there in the clear can, have your goals of care very, very scripted so that we can deliver the care that our patients are willing to have. And just making sure that that's documented within the record, that, whether there's, end of life care or plan of care choices that have goals of care have been discussed before. Check for that because that's important, particularly in those patients who have an altered mental status because they can't be their own decision makers, right? And so looking to what they've had before documented in their record is critically important, just very important to us.
We're talking about the COPD tool with Dr. Peter W. And this will be in addition to the currently existing moderate respiratory distress tool that I discussed earlier, that Dr. Peter W. is involved with that podcast as well from November of 2024, as well as the asthma tool that was created and has been up since 2023. And if you have questions about how to access those, you can access those on the ACEP mobile app as well as online on the poctools.acep.org. Easy to get to and easy to walk through in terms of helping you with some of these common presentations and bounce backs we have in the emergency department. So, Dr. W., any closing thoughts or anything else that you, with your expertise and role with pulmonary and critical care and emergency medicine in New Orleans, want our physicians to know about?
Yeah, that just maintain a broad differential diagnosis for these patients because it may look and sound like a routine COPD exacerbation, and they're allowed to have ACS, right? So the same risk factors that gave them COPD, their tobacco smoking, can play a huge role and increase their risk for ACS and then congestive heart failure. And then also this real tough management is right heart failure. And so they're set up for right heart failure. So they may have clear lungs, but complain of dyspnea and not responding to their duo nabs. And this may be a tipping point with their right heart failure, primary pulmonary hypertension, and exacerbation of that disease, which is real tough to manage. So excluding things like PE, because they're at risk for PE, because they have oftentimes now a bed to bathroom existence. The existence of CHF we spoke about and BNP being helpful for us for that. Making sure we don't have new infiltrates and looking with chest x-ray for that, understanding that CT scan can oftentimes be very helpful to these patients picking up alternative diagnoses in complicated patients that have pre-existing disease and woeful chest x-rays. The CT scan may show us underlying disease that wasn't otherwise obvious to us. So just keep in mind that those differential diagnoses are in fact broad for good reasons in these patients.
All right, how can folks get in touch with you if they have any other questions? And then we'll hit the link again and then we'll call it a day.
Yeah, and folks can email me at pdebli@lsuhsc.edu. So it's pdebli@lsuhsc.edu.
And if you're just like me, every time you meet with Dr. W, you mess up his name. It is spelled like a DeBlieux, assuming down from New Orleans, kind of that French, but it's W. We've clarified that, and thankfully I've asked before each podcast, so I didn't make a complete fool of myself for 30 minutes otherwise. But I really appreciate the time. Again, these are available on the ACEP app and as well as online at poctools.acep.org. The app is the ACEP mobile app, which is on Google Play as well as the Apple Store. As for me, you can contact me, rstanton@acep.org, rstanton@acep.org, at Everyday Med on X. We're also available on Instagram and Facebook and all those places too. But the most important thing is that you are subscribed to the podcast on whatever platform you enjoy to make sure that you get every episode. Again, if you want to expand on this topic, we have the episode that several thousand of you have already checked out from November of this last year on the Love is in the Air, Moderate Airway Management POC tool with Dr. Peter W. and Dr. Jim Neuenschwander. A couple of good, unique names that are our airway and point of care tool folks. In fact, I think I've got something with Jim coming up later this week. But check that out, dig back in, listen to that podcast as well. Great information on that moderate airway management. That was before Jim's team, the Ohio State Buckeyes, won the national championship. So he was still humble at that moment. I can't guarantee what's going to happen coming up in the next number of weeks. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.